So thank you so much, the audience, for being so patient. I think since morning we've been witnessing an amazing group of people, the keynote speeches, and now this panel discussion. So everyone knows all the members on the dais, and most of the questions that I will be addressing to you all are practical questions which have come to me as a clinician, as a geriatrician, as a palliative care provider. And they are the ones which come to us from families as well as the patients. So I would expect, and we would request you all to give personalized anecdotes as well that will help our audience to relate to them. Let me start with Dr. Anil Kumar Anand. We have seen that the decision-making capacity of the patients lies a lot in their family members. And has there been any incident that you can recall wherein the patient's family members or the caregivers have refused or denied or not accepted the treatment option that you have suggested just because of the age or other factors? And if yes, how do they decide and how do you counsel?
When we encounter the patient first time, it is, I think, quite a difficult task, and because that is the first meeting we are having with the patient and the family. But I a little bit disagree with your question, and that is that patient's family. I feel the patient has to be number one, especially in cities. So we have a divide, of course, between the cities and villages, but the place where we are sitting, I think patient should be the central figure to decide. So what I was attending a meeting, and where they use the word that many times we tell patient to sit outside, and in many places, and the family comes and discusses with doctor what is the line of management, what is the expected outcome, what are the side effects, how bad or good life would be, etc., etc. And the patient sitting outside feels there is a conspiracy going on. That is the word that was used in a palliative care conference, because patient is intelligent. Most of the people we see they have seen life more than their caregivers. So they are sometimes, they have retired from a very good position, government positions, and just because they are frail, they are sitting outside and thinking that these young people who have gone in, they are trying to take decision for me, which is, I think, in the current era is not acceptable. We, in the first go itself, it's my policy to bring in the patient himself also with the family. We cannot say you sit outside and the family will take a decision. And therefore, the question is how to talk to them and what all we can talk, and then I can answer your question. But my first thing is that the patient should be the central figure in decision making. Sometimes there are some issues where, suppose the outcome is real poor, then it is left to the craft and art of the doctor and the people around him to tell. But ultimately, patient has, second point is, if we don't tell him, somebody else is going to tell him. Now that somebody else is also very important. I think there may be people who would know that other people may be his friends, his Google, his acquaintances, his junior colleagues in his workplace or wherever he lives. So therefore, even if we try to hide the information, it will reach out to him, and then he will feel more shattered. So therefore, the thinking amongst doctors, I feel it has changed in my mind also in the last 10-15 years. It is no more a time where the only caregivers are involved. The patient should be the central figure.
Thank you so much, sir. Very well explained. And I think this is one of the take-home messages from the entire conference as well, that keep the entire treatment plan, keep the entire management patient-centric. That's very important. Coming to you, Dr. Mahajan, being such a senior figure, you've seen a lot of times in the last few decades. And especially nowadays, we are seeing a part of this, the trend is at the drop of the hat, all kinds of physicians, not only oncologists, are writing PET CT scan. And PET CT scan has become a kind of a trend wherein sometimes it's not even required, and it is a harsh truth. So how do you compare it as with the conventional CT scan? And if this trend has to stop even in a not so resource limited setting like ours where we are sitting, what are your comments on it?
Thank you very much. That's a very important question. I do not think that general physicians are writing PET CT scan. At least that has not been my experience. We've had a PET CT scan for over 17 years now. Initially, even the oncologists were very hesitant to write. Those were the early days of PET CT in this country. And if we come to 2024, maybe for some follow-up CT scan, PET CT, in consultation with the oncologist, a physician or a GP may write it, but decision making on their own, at least in this city, I can say for sure, it doesn't happen. So it would be, and also at the initial stage, when, maybe someone may suspect that there may be cancer, it is not generally a PET CT that is asked for unless one has traversed some degree through the healthcare system, reached to oncologist who is now reasonably certain, and then he asks for it. Initially, I think in our setting, depending on whether it's the chest or it's the neck or the abdomen, it would be for the chest generally a X-ray of the chest that is asked and an ultrasound to begin with for the abdomen. And based on the ultrasound report, especially when we talk of the abdomen or even the neck, at times it is a CT scan that's done, even when there is a consideration that it may be a malignancy. That is where, over the years we've learned, not only here but across the world, that maybe at that time, to reduce duplicity of scans, you do a CT scan first, then you do a PET CT scan. I would say we need to go for the most appropriate test, and in some cases it may be a PET CT, because in these 17 years we've been doing a diagnostic CT along with a PET scan. Actually, this was since 2007. I, being a radiologist, and with a PET scan, in the abdomen, if you do a plain CT, it's absolutely non-diagnostic. Similarly, in the neck, in the chest, it may still be sufficient. So for 17 years, and that does two things. It reduces doing two separate tests. It reduces the overall radiation dose to the patient, and it also reduces the overall cost. Because what we started doing in 2007, when it was a non-diagnostic CT with PET, it was a certain figure, and a diagnostic CT where contrast is injected, the whole body diagnostic CT is done, it was only 3,000 rupees extra. And that we have stuck to till this day. So overall, I think I disagree that, there is over a prescription of PET CT scans. We have, oncologists who are as good as the best in the world. They know when to prescribe. There are, set guidelines which have to be followed. And I think by and large, they are being followed. I may say that in one's own family, a doctor may tend to overdo a test, but generally they do not. And frankly, I think we need many more. I mean, if we look at the per capita requirement of diagnostic tools in this country and what we have, there is a huge gap, and we need many, many more. And actually, misconceptions of this nature may actually stymie the growth, which will be detrimental. Because, PET CT is not only used for cancer, it's used for dementias, it's used for cardiac diseases, it's even used for fever of unknown origin, and so many other cases where slowly, of course, cancer remains probably 85 to 90% of what we do. So I think we need more and more. Of course, we need a more homogeneous distribution across the country. Currently, these high-tech machines are there only in the metros or tier 1, now going down to tier 2 cities. We need them to percolate further and further.
Thank you so much, sir. So, as we said, that the purpose of this panel discussion is debunking the myths, and sir just rightly pointed out on the misconception that people have. So, moving on to Dr. Indu Aggarwal, ma'am, radiation oncology has evolved a lot in the last few years, but still one myth which exists among a lot of patients and caregivers is that it is unsafe for elderly patients. How true is that, and would you like to throw some light on it?
First of all, I would like to thank Business World for having me here, and it's truly a pleasure to interact with all of you. So answering to this question, I would say that over the years, radiation oncology is a branch which has evolved a lot, and a lot of significant improvements have been done in the treatment techniques, thanks to the improvements in imaging as well. So I would like to explain the difference between chemotherapy and radiation. So unlike chemotherapy, when you give something, it's injected it's going through the vein into the bloodstream. So chemotherapy has its effect all over the body. But fortunately, radiation is a very, very focused, targeted treatment. So because of that, and with the best machines, we are able to target tumors with sub-millimeter accuracy, even with 1 millimeter. So if I'm doing radiation these days, then we are able to save all the surrounding normal structures. Like, just to give you an example, if we are giving brain radiation for someone who has tumor spread to the brain, these days we have moved on from giving whole brain radiation to very focused radiation, high dose radiation, 2 or 3 days treatment, and at the same time we are able to preserve the memory function, we are able to preserve the hair. Similarly, if we are treating a patient with a CA prostate, we are able to save their sexual functions, we are able to save the dose which is going to the bladder or to the rectum. So because of all these advances, the radiation treatment has become a very, very safe and a very effective modality. So it can reach the places where a surgeon cannot reach. It can treat the patients where chemotherapy cannot be administered. So that's why radiation can be very safely given even to elderly. So the oldest patient that I have treated with radiation is an 89-year-old lady whom we treated, and there are so many patients, say with food pipe cancers, who are not fit for chemotherapy, but with radiation we can improve their quality of life, we can decrease the pain, we can decrease the bleeding. So we actually help make the life worth living if we are using radiation. So many patients are afraid that radiation is a very toxic treatment, and that's why they don't even discuss the option with the doctors, and on their own the family decides, no, my mother is old or my father is old, so we will not take the treatment. So I would suggest everyone in the audience here that please meet the radiation oncologist. The treatment would be different for every patient, and with radiation we are able to tailor the dose as per the site of the tumor, as per the symptoms of the patient, and we can give our treatment modalities have reduced from, say for breast cancer, we have now moved on from 6 weeks radiation to 5 sittings of radiation or even single sitting of radiation. The areas that we used to treat, they have shrunken, and the toxicities, they have reduced remarkably. So it's a comparatively a very, very safe treatment and easily done OPD basis treatment, painless treatment, few minutes treatment, does not need any admissions. So I think the myth around the radiation has to go. It can be safely given to elderly patients.
Thank you so much. You know, recently, ma'am, I'll stick to you only. Recently, it was one of our community outreach programs in a tier 2 city. And while doing palliative care counseling for a patient's family, जैसा आपने बोला कि seek the opinion of a radiation oncologist also, when we discussed about what are the treatment options that they have taken, They refused for radiation oncology because their family thought that it would be unsafe for the family members if their loved one is undergoing radiation. And मतलब मुझे ये सुन के इतना अजीब लगा that this is happening just 200 kilometers away from Delhi. Because लोग ऐसा सोच सकते हैं कि घर के अंदर अगर रेडिएशन किसी को मिल रही है तो बाकी फैमिली मेंबर्स अनसेफ हैं. So do you have any comments on it? या आपके कभी इंसिडेंट ऐसा हुआ है during your clinical practice?
So thank you Dr. Charu for bringing this up. Because I think ये 200 किलोमीटर दूर की बात नहीं है. We face this every day in OPD. If people who are CEOs, they come to us and they say कि मैम रेडिएशन तो बहुत खतरनाक होता है और क्या मैं अपने पेशेंट को घर ले जा सकता हूँ, क्या मेरा बच्चा मेरी मदर के साथ बैठ सकता है, मैम मेरे घर में 2 साल का मेरा बेटा है, क्या वो अपनी नानी के साथ खेल सकता है बिकॉज शी इज़ अंडरगोइंग रेडिएशन. सो एज आई told just now that radiation is a focused treatment. If I am giving radiation to the brain, पूरे brain को भी radiation नहीं मिल रहा है. It's a radiation is high energy X-rays. तो जैसे आप कोई X-ray या CT scan कराते हो, उसी तरह से radiation का treatment है. It's just high energy, but because it is focused, so patient does not become radioactive. It's not a radioactive material. ये जैसे अगर हम रेडियो एक्टिव आयोडीन्स का ट्रीटमेंट करते हैं फॉर थायराइड कैंसर्स, देन ऑल्सो द पेशेंट इज केप्ट अंडर ऑब्जर्वेशन एंड दे आर डिस्चार्ज्ड व्हेन द रेडियो एक्टिविटी इज ओवर. बट रेडिएशन ट्रीटमेंट्स आर एक्सरे बेस्ड ट्रीटमेंट्स, सो दे आर नॉट एट ऑल रेडियो एक्टिव. हम लोग पूरा दिन, आई एम सिटिंग इन द डिपार्टमेंट ऑफ रेडिएशन सराउंडेड बाय 50 पीपल थ्रू आउट द डे. और इतने सालों से फॉर लास्ट से 28 ईयर्स आई एम इन रेडिएशन ऑन्कोलॉजी. तो अब तक तो मुझे रेडियो एक्टिव हो जाना चाहिए था. सो इट्स एब्सोल्युटली सेफ ट्रीटमेंट, फोकस्ड टारगेटेड ट्रीटमेंट, एंड दैट्स व्हाई आई एम सो पैशनेट अबाउट दिस ब्रांच बिकॉज आई एम एबल टू टेलर द डोज जस्ट अराउंड द ट्यूमर एंड सेव द सराउंडिंग नॉर्मल स्ट्रक्चर्स. सो आप रेडिएशन करा के आपका बच्चा पोता आपकी गोदी में उसी समय बैठ सकता है, आप उसी प्लेट में खाना खा सकते हो. सो पेशेंट से आपको कोई भी नुकसान नहीं होगा, लेकिन अगर किसी को इन्फेक्शन है वो आपके पेशेंट को ट्रांसमिट हो सकती है जिससे उनकी इम्यूनिटी लो हो सकती है. सो दैट्स इट.
Thank you so much, ma'am. Thank you so much. Moving to Dr. Nataraj. When we talk about bone marrow transplant, there are a couple of questions which comes to everybody's mind, and these are also 2 myths which needs to be debunked by specialists like you. The first one is that it is definitely a painful procedure. And the second one is it has to be done only by the family members, especially men. How true are these? And if not, then do you have any comments?
Both are myths. Now, number one, bone marrow transplant is a painful procedure. Yes, it used to be about 30-40 years back when we were not having sort of a tailored treatments. And bone marrow transplant, basically in bone marrow transplant, what we do is we give a sort of a very high dose chemotherapy to begin with, and then empty the bone marrow, which is having either a disease or like thalassemia, aplastic anemia, or a cancer, blood cancer, and then we fix that place with a normal product producing blood cells, mainly from brothers sisters. So, and then whoever is a match, and then we put it, and then these things will grow. So previously it used to be like a sort of a carpet bombing. You give such a high dose chemotherapy that a lot of organs also would get damaged. But nowadays it is not like that. It is extremely tailored, and then it's not like one size fits all for approach. Now even the kids like less than 1 year or even up to 70 years, 72 years, 75 years, we do bone marrow transplants based on the age, the fitness. It's not the chronological age which matters. Somebody may be 70 years but he is still as fit as 50 years. Somebody may be 50 years who is as weak as 70 years. So we choose the biological age over chronological age, and then we assess what patient can tolerate, and then how much the chemotherapy dose that patient can be given, and then how targeted the chemotherapy can be so that it can only clear the bone marrow, not affect the other organs in the body. So it is not an operation where we go cut the bone and then push some cells into the bone. It is everything is done through IV line. So basically it is done in the blood, through the blood. It's like an IV line, and then all the procedure is done in a highly secure environment so that the patients won't get infected when they are immunity free, when they have got very low immunity. In fact, always one patient family member will be next to the patient throughout the procedure in almost all the hospitals, at least in our hospital. And then, so it is not a painful procedure, it's a procedure where the production site of a bone marrow, where the blood production site which is diseased is replaced with a normal healthy producing bone marrow cells. Now, second question is, who should be the donor? Whether it should be only male, or it should be only from the family, or it should be only the siblings. It is a myth that only men can donate. Both men and women are equally eligible to donate. Only thing is that the donor should not have a disease which can be transmitted to the patient. And second thing is, donor should be, usually we cut the age off at 60 to 65 years. We don't collect beyond 60 to 65 years. These are the two things. And both men and women can donate. Only thing is that pregnant women should not donate. That's it. Otherwise everybody can donate. Now the third myth is, if there is no donor in the family, where will the donor come from? So donors can be parents, donors can be kids. We have done transplants from father or mother to the patient, or kids like 5 years, 4 years old son or daughter to the patient. And also other way around, we also have now registries where lot of voluntary donors are there. Even in fact, I am also a donor. One of my colleagues donated cells to somebody who is unknown to the patient, unknown to her. And then anybody can become donor, and then if they are matched to somebody else, they can always donate the stem cells. One thing, unlike kidney transplant or a liver transplant where one organ will go away from the body of the donor, the stem cells are not like that. Even if you donate 4 to 5 times, there will be no harm to your body. So anybody can donate stem cells, like the bone marrow producing cells. It is collected from the blood. No more, we are not going to drill the hole to the donor and then collect from the bones. We are collecting from the blood, and then it is very safe procedure. And then there are thousands of donations, lakhs of donations have happened all over the world without major impact to the donor.
Thank you so much. Thank you. So moving ahead to Dr. Mahajan, there are a lot of companies, private companies, which are claiming to be FDA, EU approved, and they are saying that one single blood test can predict and prevent cancers, the entire universal cancer screening with single blood test. And patients get really confused. Families do get confused when they come to the doctors that is there some blood test which is 100% safe, 100% effective, they are FDA approved. So sir, with your experience and your knowledge, can one blood test really predict and prevent the entire cancer?
I don't think anything can prevent cancer if it's going to happen, except changing your habits. If you smoke or if you chew tobacco, and so if those factors are taken away, only that can prevent or maybe reduce the likelihood. But definitely there are tests available which can predict some cancers as our knowledge goes today. Genome sequencing has been around for now around 2 decades, and it came into its own in the last 6-8 years. Using that, we can actually look at mutations that happen in genes. And we know that there are some kinds of genetic cancers that can happen. A lady who has breast cancer, her daughter is at higher risk in case she has a certain mutation. Those mutations we can find out. These are called BRCA mutations. And I'm sure many of you will know of the case of Angelina Jolie, the actress in the US, who actually did the same test, and she was told that she has a very high chance of getting breast cancer and or ovarian cancer. So she was told it's 80%. Of course, 20% she may not get it, and when she is going to get it, we don't know. So instead of choosing to do very diligent screening, what is the idea of doing this test? The idea is that those at high risk do screening, like self-breast examination, mammography, ultrasound, for that specific reason, or a colonoscopy for colon cancer. What she decided, she says, I have 6 children. I cannot afford to get breast cancer. or ovarian cancer. So she actually went in and did preemptive surgery, which to many may have sounded extreme, but each person is his own master. And she chose to do that because she said, with 6 children, I can't afford to die early. And she went ahead and she actually did yeoman service for cancer awareness in the world. And, we all thank her for it. So there is this predictive test that's available. The second test, and there are a lot of claims made, and I hope that we will sometime reach a situation where with a single blood test, we are able to 100% or 99% certainty be able to pick up circulating cancer cells in the body, based on which we cannot prevent, but we can actually diagnose early that there is cancer somewhere in the body. So this is circulating DNA, which even today we are able to pick up, but the sensitivity and the specificity have still not reached a stage where it can be used for screening purposes. 2, it is also very, very expensive at the present point of time, and it's hoped that, it may come to such a stage that you can actually screen a population which is at higher risk for cancer and be able to pick up early. So to answer your question, and there are claims that are made, every day, that there's this test which is 97% accurate, but when done in a large population, where out of 1,000 you're supposed to pick up one, if you miss that also, it seems that it's okay. You only missed 1 out of 1,000, but that's the one that you were supposed to pick up. But a lot of work, lot of research, lot of innovation happening in this field to pick up, if not at population at large, but at least in those who are at high risk, and then to be able to screen using radiology and nuclear medicine techniques to be able to localize the cancer. In fact, I call PET-CT in such a situation like a Brahmastra, where you know that there is some cancer in the body, but you don't know where it is because there are no symptoms. There, FDG PET with its high sensitivity is able to localize if it is of a certain size. And now with the newer PET-CTs that are coming, we are able to pick up very small and early lesions as well.
Thank you so much, sir. So moving on to Dr. Anand, my question to you will be, sir, and we'll be a little fast since we are moving, really time. How relevant do you think is the tumor board setting in not only in multi-speciality corporate hospitals in metropolitan cities, but providing such service virtually to other cities and providing a holistic management to a patient? Do you see any kind of scope in that? And how do you see doing that in current scenario?
Very, very essential to have a tumor board, and for the knowledge of our people who are not near the hospitals, it means that the surgeons, medical oncologists, radiation oncologists, radiologists, and sometimes pathologists, they sit together and decide what is the best treatment for a particular patient. The quality of tumor board, I suspect, is quite variable in different hospitals. So it is not top of the line, I would say, in many hospitals, but in many hospitals very good. And what we need to do is that it is also for the education of people across specialties, because suppose I am radiation oncologist and I feel I can do the best for this patient. But when I put that case in a tumor board, the surgeon may give his advice and may say that, no doctor, this patient may be better treated by surgery, or a vice versa. Surgeon may suggest that I can remove this big tumor and the patient will get rid of this tumor, but I can say in radiation oncology or in medical oncology, let's shrink the tumor with chemotherapy or hormone or something, and then maybe do a organ salvage. Organ salvage means I protect the organ while I cure the cancer. So this is a very big kind of development in which the patient should demand organ preservation. Patient should say, doctor, I want to make sure that my organ remains. And the biggest example is breast conservation. However fast we are developing, even in big cities, still there is a fear among women about breast cancer, and many of them say, even for early breast cancer, doctor, remove the entire breast. And then they have regret later on in the life when they suffer psychological issues and flat chest and its attendant complications. So this kind of bigger view is in tumor board we discuss, but I think in tumor board, patients also have to be the participant. And I will request that patients should gain knowledge, howsoever Google may be good or bad, but should think, well, recently I met a lady, she's very aware, upmarket lady I would say, and she said, no, I want to get rid of my breast. Why should I have another chance of tumor coming back? I said, no, this is a myth. Early breast cancer, if you do breast conservation surgery and radiation, cure rates are same. In fact, some studies are now saying breast conservation people do better than mastectomy people. Yes. That also is coming. So therefore, this tumor board should spread across not only surgical, medical, radiation, radiologists and the nuclear medicine specialists and pathologists, but the patient and the family should be part of that tumor board. And in many institutions I have seen, once we have discussed, we call the patient and the family into the hall. And we call them that this is our decision. But sometimes I have seen patients say, no doctor, I don't accept your decision. Please explore whether I can conserve my limb, for example, in a sarcoma, or in a breast cancer, or in many other situations where organ must be spared. It is the best thing which we can have with current technology. Now we have technology in surgery, we have technology in radiation, in technology in many times we do induction chemotherapy, maybe for example tongue. We can spare the tongue. We may not sacrifice the 2/3 of the tongue by doing some pre-operative treatment and then doing chemoradiation. So I think it is a huge topic, and I must say that the time is prime time for our personalized medicine. Medicine is getting more and more personalized. It is not same copy-book treatment for everybody. Breast cancer, you do mastectomy, you give chemo. No, it should not be. The lady in question or the person in question should demand that I need this kind of treatment, and I can tell you most of the demands can be met.
That's wonderfully put. Can I have the liberty of asking one question? One last question. That would be to Dr. Nataraj. And Dr. Nataraj, my question is that these days the hot selling cake is CAR T-cell therapy. And everyone is talking about CAR T-cell therapy for every kind of a blood cancer or lymphoma. What is CAR T-cell therapy in 30 seconds for you? And in what reasons or in what situations should it be used wisely?
CAR T-cell therapy means it's taking away one's own immune cells, that is T cells, and then sticking them with sort of targets, which can go and find where it has to go and then kill the things, and then kill the cancer, and then these T cells or the immune cells will go and release some toxins to that specific area so that it kills that cancer cell, and then it can move to the next cancer cell to kill. And also they have got the ability to self-renew, means they can divide. If you give one CAR T cell, it can become 1,000 CAR T cells inside the human body. And also equally, it is important that it should be given to the right people at the right time. So usually CAR T cells now work best for blood cancers, mainly acute lymphoblastic leukemia. It works good for lymphoma, B-cell lymphomas. It works very good for multiple myeloma. There are many other diseases which is getting there are a lot of other diseases which their trials are going on, but these are the only 3 diseases which have shown proven efficacy. But in all the 3 diseases, it is given at relapse setting, not at first setting, and then in majority of the places it is not a replacement to the existing treatment modalities. It takes some more time for the CAR T cells to move ahead in the line of treatment. Maybe it can become first or second line treatment in coming decades. And also equally very important, every CAR T cell doesn't work the same. That is very important for you to know, because Carticel is not like a drug biosimilar where there is a rituximab which is there in America, which rituximab is there in India, it works the same. It's not like that. It is Carticels are vector dependent, and then vectors are different from different products to products. So it is important that Carticel of, for example, Tisacel in America will, if we take it as reference, the cells that we get it from somewhere else will work the same as both. So it is important you ask the doctor whether how is the efficacy, what is the data, and then how the things work. And then it is very important that yes, it's a very good modality of treatment, but this is not a replacement to existing treatments.
Thank you so much, Dr. Nataraj. So our questions are never ending, but the time has come for all of you to enjoy lunch. And thank you so much to all the esteemed panelists, and over to the organizers. Thank you.